And for how long?
Okay. First of all, I totally agree that we do have some problems with the bisphosphonates administration. Not if the bisphosphonate is needed for myeloma, because I strongly believe that we needed anti-resorptive therapy for multiple myeloma. And this is mainly because we know very well that the osteoclast is a key cell for the myeloma cell growth. And that is why the myeloma cell wants to induce the osteoclast function and to reduce the osteoblast activity. So I believe that the osteoclast function is very important for the myeloma cell growth also. So we need an anti-osteoclastic therapy. If the best is the bisphosphonate or the new agents like adirondack or the new agents that are going to enhance the osteoblast function like a DDKK1 or a sclerostin agents, I don't know. But I really know that we need an agent that inhibits the osteoclast activity. So this is first from the biology point of view. Okay, this is important. Second, which is the best? We really don't know, but according to the evidence that we have and the studies that we have, it seems that the intravenous bisphosphonates are better than the oral, like clodronate, because oral clodronate has also an absorption rate of below 1%. So possibly this is why the zoledronic acid was found to be better than clodronate regarding skeletal-related events. And I don't talk about survival. I'm talking about the skeletal-related events first. So it is, if you don't give any therapy at all, you are going to have 50% of skeletal-related events. And when we say skeletal-related events, we talk about pathological fractures, need for surgery or radiation therapy, meaning complications that are devastating for the patients with multiple myeloma. So if we don't give any therapy, we're going to have something about 50 to 55% of patients with skeletal-related events within 2 years.
Within 2 years
within
of
2
treatment?
Years.
Of treatment or
No,
without treatment?
Without anti-resorptive therapy.
All right.
If we give oral clodronate, this goes down to 35%, 37%, something like that. With zoledronic acid, it goes down to 25%. So I believe that you need an intravenous bisphosphonate. Which one of pamidronate or zoledronic acid? The randomized trial showed that both agents are equally regarding efficacy in skeletal-related events. So I cannot say that pamidronate or zoledronic acid is better. So the MRC9 trial showed that zoledronic acid also has a survival benefit. However, we need to see the full paper in order to see in which subset of patients, or if this 5.5 months of survival advantage in the whole populations gives something more to some population, like 12 months in a subset of patients, or something less in another subset, in order to be more strong about that. So, till seeing the full paper, which I know that has been submitted to New England Journal of Medicine, but I don't know it's the review process, the result of the review process. So, zoledronic acid and pamidronate, for me, are the recommended bisphosphonates. Let's go about the dose. For zoledronic acid, this is, I think, clear, it's 4 milligram monthly. For pamidronate, I've seen the Nordic paper comparing 30 to 90 milligrams, and they've shown similar efficacy. To suggest 30 milligram with all my heart, let's say, I would be more willing to see a study comparing 30 milligram with 4 milligram of zoledronic acid, 30 milligram of pamidronate to 4 milligram in order to be more sure on that. In my clinical practice, we give zoledronic acid definitely for 2 years. And then, if the patient has active myeloma disease, we continue. If the patient is in CR, let's say, probably we stop. Of course, if we see a survival advantage from the MRC9 trial, possibly the guidelines are going to change. And because I have written the European Myeloma Network guidelines, I can assure you that even from the International Myeloma Group, with Brian Jury told me that we may, when we see the paper, the new paper, we may change the guidelines, but this is a matter of debate now. We need to see the paper, to see the full administration, because we know that the follow-up is 3.8 years, but we don't know if during this period of year all patients were under zoledronic acid or if they stopped after 2 years. We don't know exactly the administration median period. We know the median follow-up of the study, but we don't know, I talk about the MRC9 study.
Right now they stop after 2 years, right?
We stop after 2 years, definitely for patients at CR, or even very good partial response, but with patients with active myeloma, we continue because probably from other cancers, we know that zoledronic acid has an anti-cancer effect from breast cancer, there is a survival benefit. Possibly in myeloma, if the MRC9 trials results are true, and we are going to see, of course they are true, but we are going to see the full paper. And I believe that if the patient is in CR, then 2 years are okay. For patients in partial response, possibly we need to go further due to this possible anti-myeloma effect. Regarding side effects like osteonecrosis of the jaw, the two prospective studies, the MRC9 gives an incidence of 1% per year with zoledronic acid. The study comparing zoledronic acid with denosumab, the anti-RAM, gives an incidence of approximately 1% at 2 years.
Okay.
So, nevertheless, it's approximately 0.5 to 1% per year. This is the risk for having an ONJ. If you balance it with the very good effect on the bones and the reduction of the skeletal-related events, I strongly believe that bisphosphonates are an important agent for the myeloma therapy. Okay, first of all, we have evidence from bone markers and evidence from small subsets of patients who receive bortezomib in combination with zoledronic acid, that we have an increase in the bone formation markers first, and we have an increase in bone mineral density in a subset of patients. We published that this year in Oncology. Regarding phase 3 trial, the only phase 3 trial that has also looked at skeletal-related events is the VISTA trial, where the combination of melphalan-prednisone plus Velcade was compared to the combination of melphalan-prednisone. So in this specific study, the authors, and I am the second author in this study, Michel Delfos is the first author, found that the addition of Velcade to MP managed first of all to reduce the DKK1, the DKOP1 protein, which is a very strong inhibitor of osteoblast function. On the other hand, patients who had treated only with MP had an increase in the DKK1 protein. So first of all, that one. Second is that the need for bisphosphonate therapy was higher in the MP versus MPV. Regarding skeletal-related event, within this period of the study, which is very short, I think it was something between 14 to 11%, 14% the MP versus 11% the MPV. But possibly after 2 years, this difference may be even bigger. So we have the biochemical evidence that bortezomib has an anabolic effect on the bones. We have evidence from small studies that we have increases in the bone mineral density and healing of the lesions in MRI. And from the VISTA trial, we have also strong evidence that we have biochemical advantages, and also some patients, and I have shown in my talk on Sunday 2 very interesting pictures, one with MRI and one with all skeletal survey, showing that lesions in the skull, let's say, with normal radiography, were vanished after the 9 cycles of VLP.
Okay. Unfortunately, as you're running out of time because you have to go to the seminar, I'll just jump to the last question.
Okay.
And this is, what do you expect for the next decade? Are we getting closer to the cure of multiple myeloma? Are we going to see it as a chronic disease?
If we say that cure means to increase the survival, the median survival to 10 years, I believe that we are close to that. We are going to have new IMiDs, the carfilzomib, the pomalidomide, new proteasome inhibitors, the carfilzomib. We are going to have novel agents like HDAC inhibitors, which seems to be very active in combination with bortezomib or lenalidomide. So I strongly believe that these 5 years of the elderly and 7 years of the young patients that we have now, meaning patients below the age of 65 or eligible for a transplant, because this is the median survival in our center and also in other centers also. This is going to be near 10 years with all these new drugs that are going to be in the market within the next 4 or 5 years.
That's a good prediction.
Yes.
And making it a completely chronic disease, do you think there is a target? Can we put it as a target?
I don't know. I don't like very much, the terminology chronic disease. But if you mean to have patients with, let's say, is breast cancer a chronic disease? If we say that breast cancer is a chronic disease, because I have not seen something like that written anywhere. We say we have breast cancer patients with long survival. Okay. So if we say chronic disease, someone who lives for more than 10 years, then I think that yes, we are very near to that.
Okay.